That's great. So good morning, good afternoon, colleagues, and thank you very much, dear Lubna and colleagues, for inviting us actually to this region and to dedicate a session, a specific session to cover the regional perspective and the success stories from our region. And when I speak about our region, I'm speaking about the Eastern Mediterranean region, WHO, which covers 22 countries, whole spectrum of countries from so many from actually both continents, from Africa and Asia. So we cover countries, the 22 countries cover most of the Arab countries, in addition to also Iran, Pakistan, and Afghanistan, population of about almost 800 million. And of course, as you know, it's a region that's, as we like to say, it's very diverse, very dynamic, but also has a lot of countries, and actually the largest numbers of countries that are in some kind of emergency or conflict situation. Many of them have been in conflict for years, chronically, and this has had significant impact overall on our capacity, our health systems, and also on our capacity research. Although in view of the pandemic has highlighted for us, like for many other regions around the world, the many gaps that are in our systems, in our ability to conduct research. But also the COVID pandemic brought with it a lot of opportunities. It's, I keep saying it's the silver lining, although to be honest, there's nothing good about a pandemic that has killed so many people and has destroyed not just lives, destroyed economies, and has had such a major impact on the world. But it has led to a significant amount of innovation, of investment into research, because of the necessity. So necessity is always the mother of invention. And for our region, you will hear from my colleagues, from Dr. Rashidian, Dr. Mehrnaz, Dr. Mandil. You will hear from them about the many success stories in the region, but also many of the issues that we had to deal with, how in the middle of the pandemic we had to establish capacity in the region to really conduct the scientific studies that were needed to be able to respond to the pandemic, whether it's participating in clinical trials for drugs, for vaccines, for diagnostics, etc., to the need to also conduct, many other studies later to evaluate the effectiveness, the vaccine effectiveness, etc. The issues that we had to deal with in terms of actually the translation of science and all this evidence that was accumulating very quickly during the pandemic to policies and to really to materials that policymakers can use to make the right decisions during a pandemic that was evolving so quickly. So I think we've never seen such a boom in research in our region in such a short time as we have seen over the last 2 years. And in many ways, I hope that we benefit from that momentum that was created during the pandemic. And don't forget very quickly, in public health, we have always been afraid of these cycles that we call the cycles of panic and neglect. So whenever we have an emergency, health emergency or other, we kind of panic, we run around to try to do the right things, and then later we kind of forget and go back to the normal. After COVID, we should never go back to the way things were. We should take advantage of all this momentum that was generated by the pandemic to really build on it, and as we say, to hit the iron when it's still hot. In particular, for us, for research capacity, I think Lubna knows, and many colleagues, that this is an area I feel very strong about investing in research in our region, and all kinds of research, but we are very much in need of applied public health research. I mean, this is what the region needs so that we can strengthen the evidence-based or evidence-informed, another term that we've been using lately, to make decisions that are evidence-informed. I was just mentioning to colleagues before the call that I'm actually joining you today from Berlin, where I'm at the World Health Summit. And it is, it's much larger meeting than its previous meetings, but there's been, we hear about the issues of the need for better data, the need for better evidence, and the need to strengthen the infrastructure that will lead to that evidence. We've been hearing about it all along. The meeting started yesterday. So for the 2 days, this has been one of the issues that was highlighted repeatedly, how we need better information systems, better data, better research, especially regional. We need that regionalization of research because we cannot in the region make our decisions based on data just produced globally in countries that often differ significantly in terms of their epidemiologic context, but also their socioeconomic context as well. So I think that regionalization is really important. And we just finished a panel about regionalization and global health and how can the discussion kind of changes from just looking at all the global issues to start focusing on regional needs and adapt and customize the tools and the approaches to also meet the needs of regions and countries even more importantly. So with that, I don't want to just keep you waiting longer for all the more meaty stuff that will come from my colleagues, and I will pass it on to Dr. Arash Rashidian. And just as a little bit of an early notice, I'm going to have to leave to go back to the meeting in about 45 minutes. So Dr. Rashidian will be continuing to chair the session on my behalf. So over to you, Arash. Thank you very much.
Many thanks indeed, Dr. Hajjeh, for introducing the session and also chairing. And colleagues, good morning, good afternoon, good evening. Assalamu alaikum, bonjour, whatever language you have. So it's great to be with you. It's excellent to be in this call. I'm grateful to colleagues who are hosting the conference and the way that Professor Lubnan Al-Ansari has planned it, and it's our pleasure to be with you. So as Dr. Hajjeh mentioned, that we will have 3 presentations. So I will start and will be followed by 2 senior colleagues from WHO. I will cover, so let me share my slides from here. Can you see the slide set?
Yes.
Okay, excellent. Many thanks. So I will cover the main picture, the sort of how WHO in this region supported generation of research and evidence and use of research and evidence for COVID response, pandemic response. And certain areas of it, will be covered in details by my colleagues. So Dr. Mandil will cover support for individual research studies within countries of the region, so through call for proposal, as well as enhancing ethics for research under emergency. And Dr. Kheirandish will cover the issues related to some case studies that were conducted in 13 countries of the region on use of evidence for policy making, as well as the support the WHO is giving to vaccine effectiveness studies. Okay, with that, so I start my talk. I have 2 short introductions. Obviously, it's 2022, and just remember, if you can remember 2020, sort of early on in the course of the pandemic, and the amount of unknown answers, amount of unknowns that we had in terms of what to do with the COVID pandemic. So there are still questions remaining, some of the lists that I've put in here. So origin of the disease, the virus, how to diagnose it. Right now, that's very well resolved. There are so many different modalities of doing that. Some of them are very rapid and also can be conducted cheaply, but that wasn't the case at the start. Clinical management, similarly, short and long-term trajectory, which is still the long-term trajectory, has questions. Transmission, preventive behavior. We didn't have any vaccine. It took several months to have the early vaccines coming, and then also efficacy, effectiveness. With the remaining vaccine, the vaccines that are in use, many of them, there are questions about the longer-term effect of the vaccine, and also the behavior related to variants of concern, etc. So with so many questions like this, research was a necessity, wasn't a luxury, was absolutely needed. And that was why WHO role in research on COVID became very important. There was a global program going on, but in this region also, certain innovative approaches were followed by the decision of WHO to enhance those capacities for research and also for use of research and data for policymaking. The other in short introduction I'm going to give is related to a decision that ministers of health of the region made just before the pandemic. So that was in October 2019. So the decision was made for enhancing use of evidence and evidence from research and data in policy making, focusing on national institutional capacity building for evidence-informed policy making. I'm not going to the details of this framework. I'm just referring to it here. And sort of that was a decision that gave some focus, I mean, further focus to work of WHO in the region. It was from several fronts a pioneering resolution, and I will cover this further in a talk that I'm giving a plenary tomorrow. So if you are interested, please join that talk. But this meant, I mean, sort of while there was a focus on enhancing action on this, we were hit by a pandemic. So the pandemic just came after this resolution, just a few months after that. And in a way, our action related to the resolution and also any other action related to enhancing health information system and research was affected by the needs of the pandemic. An important decision was made, and we have Dr. Hajjeh with us on the call as the chair of the session, and I mean, she had a determining role in that decision. So to establish, so I mean, so let me give this background to colleagues who are not from WHO or not from Ministry of Health. As you know, in important emergencies, usually there are new structures established. These structures are beyond the usual, I mean, the structure of the office. They bring different things together for response to the pandemic. So incident management teams, we call them in certain organizations, including within the WHO. So within these teams, I mean, different. So for example, I'm director of the science department and the science information and dissemination department. So this is not part of emergency structure, but when an emergency such big happens, all the departments join together. So the WHO decided to establish a new pillar within the incident management team, the pillar for research and knowledge management. And that brought every activity related to these topics, I mean, research as well as knowledge management under one pillar. That means all the departments within WHO became involved with that. The work with the country offices of WHO became consolidated, including also the work with other regions as well as the headquarters of the WHO in Geneva. And then closely working with the countries on those areas. So the pillar, in terms of that structure and approach, had 3 areas of focus. And I try to cover those 3 areas of focus. There is also a paper that has been published in the BMJ Global Health recently and covers, I mean, very briefly the areas of work that happened in this structure. So the areas of focus were enhancing capacity for evidence generation. So we will hear very good examples of this, I mean, from both Dr. Mandil and Dr. Kheirandish. The issue of timely provision of available evidence, whatever evidence exists to make it more available, better available. Again, we will have some examples I refer to in my talk, but then further details of that, I mean, will be covered in the Dr. Kheirandish presentation. And also enhancing capacity and experience sharing in use of evidence, how it's been used in practice. So all those elements are of absolute importance to the work of the WHO with the countries and in support of countries in their response. So there are several areas of work, and on every slide or maybe a couple of slides, I cover certain areas. One important area was about the seroepidemiology of the disease. I mean, the epidemiology of the disease as it happened. WHO established a specific protocol for conduct of seroepidemiology surveys in countries. So they were called unity studies as a general title, and there were a family of studies. So such studies were conducted in different regions of WHO, including in our region. And that meant, I mean, similar methodology as far as possible. Also, adjustments were conducted, especially early on in different countries, to make them happen under those difficult circumstances. But they also meant that consolidating these surveys on top of each other, generating new evidence based on that became possible. And there are the studies that WHO has pioneered globally, bringing all these surveys together. So as you can see, many studies were conducted with direct support of WHO. So I mean, in some of these, the support was only methodological. For example, the study in the UAE, but in most other studies, it was also supporting in terms of logistic and also financial support from WHO. We had sort of different category, different types of surveys. I mean, countries that they did only one survey, countries that they did different rounds, and then use those different rounds in answering policy questions as the trajectory of the disease was changing. The importance of this consolidated work was that most of these surveys were conducted in a very short period of time. They involved direct sort of engagement of teams, that some of those teams didn't have that much of past experience in larger scale surveys. So it was a lot of capacity involved in certain countries. In other countries, I mean, mobilizing the already existing resources. And if you recall, in some of these periods, the time of these studies were time that movement of the population, even in the country, was difficult because of COVID-related restrictions, then the importance of these surveys become important. WHO work in the region also helps answering certain questions beyond the epidemiology of the disease in the countries. For example, when we were applying the surveys, obviously you need to make the sort of assessment of, so the blood samples were taken or from those study for rapid test as well as the PCR related assessment. And the results were also used to test different technology that were being introduced as rapid test processes. So the studies that were conducted in the region actually help also globally to establish evidence of which rapid test technology works better. And that was also an important aspect. Again, I mean, I just want to highlight the way that the studies work. So they also involved to mobilizing resource generation for the conduct of such a study. So if you want to do rapid tests, you need to have the kits. Those kits, many of them were not built in the countries. They had to be transferred to the countries. Again, remember all those early months, restriction of travel, very high demand for whatever that was needed for diagnosis or prevention or treatment of COVID-19 disease. And that meant, I mean, a very important logistic process was established within the WHO to assess the need to transfer those resources required, but also enhancing national capacity. So it was a separate agenda, not for research purposes, but WHO, as you know, also established, enhanced the capacity for PCR testing in several countries of the region, while at the start of the pandemic, those countries didn't have that enough capacity. So this is one area of work, and very consolidated several months of work of a large group of colleagues within the regional office and HQ, but also mainly from the countries as well, alongside the Ministry of Health and researchers on the ground that conducted this study. The other area, I'm not going to give details of it. I mean, Dr. Kheirandish will give further details, but vaccine effectiveness studies, many examples, I leave it to that talk. Another important area of work, I mean, something that probably all of you have heard, country randomized controlled trial that was conducted for assessing COVID-19 treatment. So that involved assessing, I mean, 4 different treatment approaches for the COVID-19. And globally, our region was probably one of the largest contributors of, in terms of the number of hospitals involved. and also the number of patients recruited in this study. And for that, I mean, we felt great for the commitment of the countries of the region and also research capacity. So, I mean, as you can see, Iran, Saudi Arabia, Pakistan, Lebanon, were very directly involved in the study, but then there were second rounds and other countries of the region, including Egypt, Oman, and others joined the other rounds of the solidarity trial. So in that sense, I mean, that was a major also enhancement of knowledge based on this study. The other area, that's the area that my colleague Dr. Mandil will give full details of it. I'm not going to go to that, but basically it was identifying priorities and then asking for proposals to conduct it. When we talk of evidence for decision making, a major source of evidence is data. And as you will see in Dr. Kheirandish presentation, data is one of the main factors for policy making, especially at the time of sort of quick decision making under emergency. One key factor of data is data related to death. That is, I mean, sort of knowing the exact timing of people who have died, age, gender, obviously, and the cause of death. So there is a program for this, for enhancing registration and certification and reporting of causes of death that WHO supports over the years. There has been important improvements made in the region in the last few years. But still, there are a lot of limitations. And unfortunately, our region is still far from the ideal place. One impact of the pandemic was that many policymakers realized, I mean, the importance of this. I mean, policymakers who are not dealing with data, or even in ministries of health, those who were not sort of seeing the reports, but probably were not realizing how important it is the accurate certification of this. At the time of COVID, it was a political question as well as a policy question, that how many people have died due to COVID. And then when the question was not easily answered, everybody realized how important investment in this capacity was. And so this is a picture, I mean, prior to the pandemic, but then some very beautiful examples of enhancing the capacity happened in countries of the region. I'm highlighting 3 countries that they made important improvements in the data, but they also reported very regularly to WHO the data they had on a weekly basis, the data on mortality, but which meant that data was also very helpful to WHO to assess this impact of the pandemic at the global level. So especially, for example, in this case, you see the case of Lebanon, was important that, I mean, just a couple of years before the pandemic, Lebanon did not have any national strategy for the reporting on causes of death, but within a short period of time, not only established that program, but also enhanced it in a way that they could report on a weekly basis with a reasonable quality of certification of this. Similar sort of, I mean, the regular reporting happened for Tunisia for a period of time during the pandemic. Another notable, I mean, the use of the data was from Oman. And then again, Oman had a good capacity initially on CRBS to start with, but then CRBS is civil legislation and vital statistics that reporting cause of death is part of that program. So Oman had a good capacity, good system there. They enhanced the quality of reporting, but also they sort of improved it to weekly report, as you can see in my graph. So in the graph, you see there is a line that is in red and another line in black or blue. The line in red is actually reporting of deaths due to COVID in 2021 compared to the previous year. And again, sort of, you can see, I mean, visually, what was the impact of the disease as the pandemic trajectory was expanding, and how little by little it started to subside in terms of impact on mortality. So obviously, I'm not going to refer to the global study, and as you know, the data from countries was also used to assess what we call excess mortality. That means the deaths happen beyond the usual as a result of the pandemic. Why do we say excess mortality but not mortality according to because of the COVID itself only? Because, I mean, during the pandemic, it's not just that the disease causes mortality, but the disease may result on other things that may enhance mortality. For example, because of the disease results that, hospitals becoming totally occupied, routine surgeries might be cancelled, or patients might become worried to travel to receiving the care from a doctor, or receiving medicine, or being admitted to a hospital. So that the mortality for other causes might also be increased indirectly due to the pandemic. There is also it results in social dynamics that may increase or decrease mortality. So when we talk of excess, that means we look at all the factors together and to see what might be the overall impact of the pandemic on mortality in the society. Another area of work was about evidence sharing. So IMST stands for that incident management team that I referred to. Early on, my colleagues in WHO remember that. We had daily meeting of IMST, and that early on, that was for about 6 months. So it started 7 meetings every morning during the week. Just shows after a couple of months became about 5 meetings for every week. So that and that continued for at least about a year until it's the need for the meetings reduced as we knew better, and then the response patterns had become better. So continued as 3 times per week, 2 times per week, and so on. So the reason I'm highlighting this is that, so as part of that meeting, within that meeting, every pillar, so pillar that was dealing with the sort of provision of services, distribution of resources, diagnosis, social measures, national policies, etc., service delivery, every pillar was supposed to give reports. And within those, at least for about 6 months, the research and knowledge management pillar, every morning would give a short summary of what is known by the night before, what is new is known about the disease, about this diagnosis, about this treatment, about vaccines that are being developed, which vaccines on the pipeline, how they are progressing, studies in our region, etc. So that meant also the teams, for example, the science teams are usually, I would say in terms of the process, slower because of, you need to do critical appraisal, you need to assess, so they are not used to emergency situation. However, as a result of the pandemic, everybody was in the need of that. We need to have such reports. And then, as I said, for a very considerable amount of time, the teams were providing the best evidence fastest possible. It was also done, so IBC is within WHO family. Within WHO family includes, in our region was all countries of the region joining, as well as all teams within the regional office based in Cairo. So and that included senior colleagues, our regional director, as well as senior colleagues at national and regional level. The other issue was that we established a health knowledge management portal. A former colleague of us and late Mr. Hatem Nureddin established this portal, and the focus of the portal was to bring evidence that is generated into the literature, have a small group of colleagues to look at the identified literature to see which ones are more relevant to COVID response, and then make them available through a portal. That was the summary of the portal was shared with the key target groups twice per week to make sure that we are also aware of the best available evidence. And then lastly, the regional journal, Eastern Mediterranean Health Journal. So with my colleague who is on the call, Dr. Mandil, and also other colleagues that are involved in the journal, we made sure that the COVID-19 became prioritized. We made sure that although the number of submissions to the journal almost doubled since the start of the pandemic, we made sure that it remained on time and responded. And then obviously, right now I don't have the correct figure. I think there has been tens of publications related to COVID in the journal, many of them from countries of our region, so that we can also a source for sharing those processes. Then the issue of the case studies of use of evidence in response. So this will be covered by Dr. Kheirandish. I'm skipping this slide. Now I go to another slide, and here I'm actually from now on I'm trying to wrap up my talk and getting to my main overall messages. So obviously, so far I've covered the importance of science and what WHO has done to enhance science in terms of COVID response in our region. What I gave as terms of examples is a very short, brief example. Obviously, the work has been much bigger, and there is also a lot happening in the countries that is not covered in my presentation. So good science is the key. Absolutely essential. It wasn't a luxury. It's not a luxury, and it's important. However, we also observe challenges as a result of science, or challenges as a result of not following science the way it should have been followed. So first of all, I mean, we realized that there were too many research studies that were poorly designed or poorly conducted. So we did a survey early on. I mean, by early, I mean about a year, over a year after the start of the pandemic. We assessed 300 randomized controlled trials registered in EMR countries. So these are, I would say, sort of better randomized controlled trials, at least because they are being registered in international databases. Unfortunately, and these, I mean, they also have ethical clearance, and that's one of the conditions to be able to be registered. Unfortunately, many of them had a design or a capacity or a topic that did not, even at the start, when you look at it critically, it was not going to make any useful information for COVID response. I mean, so let's say imagine a randomized controlled trial for COVID treatment with a target sample size of below 100, and 70% of these 300 randomized controlled trials had a target sample size of below 100. That's bad science. That's bad use of resources. That's doing a research that is not going to help decision makers, is not going to help policymakers and also patients. And at the same time, many of these studies were focusing on treatments. So some of them, I mean, at the start, we didn't know whether they are effective or not, but some of them, they continued. You can see the list of the most common studied topics in the region in the sort of infographic that is on the right of my slide set. But then even after, for example, we knew that hydroxychloroquine, I mean, based on larger studies that have been published, we knew that, I mean, it's not going to be effective, an effective treatment. Still, there were studies that continued. And then with many studies having the same topic, the question was why at the national level, there wasn't a process to join these studies together, make it a larger sample size, so that that responds the policy, like what we did in certain countries, but also globally, as it was led by the WHO. The other big challenge that was identified was problem of interpreting research findings. So bad interpretation of the research results, making conclusion based on smaller studies, suddenly announcing that we found a miracle treatment, which wasn't a miracle. And so we usually blamed, I mean, policymakers blamed, I mean, no, there are clinicians who don't know, policymakers or media. But then we also see scientists who do that as well. So there were cases of people who were researchers. They were actually misinterpreting their own research, making generalized conclusion based on a research study that was not sort of answering the question the way it was being claimed. So that was also a big challenge that was observed. So in a way, that's a sort of, I mean, one could call it abuse of science or research processes. Even so, I mean, there were cases, there weren't many of sort of fortunate, I mean, but there were at least a couple of cases that we observed in the process that the research team, they had got ethical clearance to conduct a trial on a certain remedy that they had, but they had claimed to the media that we have ethically received the support for use of that remedy. So which is a sort of a total abuse of sort of scientific processes, and then using that, I mean, in the media for the general public that may misinterpret the message given by the
Arash, hi Arash, sorry to interrupt. Can you please wrap up soon?
Sure, I'll do that, yeah. So concluding remark. So obviously the role of WHO, as you can see, is a major role as highlighted sort of in my presentation so far. And apart from WHO, also in general, we know that, I mean, research has already helped substantially in public policy response and reducing morbidity and mortality, better decision making, and still continuing to answer the remaining questions that there are. The challenge of pseudoscience and infodemic is real, was real, and it continues to remain real. So, and based on that, WHO developed a framework for managing infodemics, and that framework has resulted in sort of a lot of further work globally, and also in terms of studies that can shed more light on the process. As I said, where there was collaboration and coordination, it resulted in better conclusions, and when we saw a lack of collaboration or limited collaboration, that was not a good sign. So collaboration is the key, and not enough research was conducted on assessing the impact of social interventions and preventive measures. Further work in these areas is absolutely important, and also for future pandemic. And lastly, as it will be covered also in the ethics talk that Dr. Mandil is going to give, is that systematic guidance is important. So I finished by this slide. Also, colleagues that were in the pillar, they were involved in the process of work over several months. Thank you, Dr. Hajjeh, and back to you.
It's great. Thank you very much, Arash, for this really comprehensive overview. This is a topic that will take actually a lot longer to discuss, but looking at the schedule, I'm happy to see that this is just kind of the beginning of the discussion, and I hope that throughout the meeting, there will be reflections on also the country's roles, perspectives shared from other colleagues and countries and academic institutions. Maybe a couple of comments before we move on to the next speaker, but I think for the discussion, maybe to get colleagues online to start thinking about questions, because that's really the benefit of these meetings, even though it's virtual, is to really hear from as many people as possible and to share ideas, but would like to hear about also country-based experiences when it comes to, all the research studies, many of the issues you mentioned. For example, for us, for incident management, I think this is the first time in WHO management of outbreaks or pandemics that we actually set a special pillar for research. And that's something I think we were probably the only region that among the WHO regions that set specific research for a pillar early on actually in the pandemic. And it served us really well for so many areas. Would be good to see whether this was incorporated in some of the countries' response management, incident management structures. The other thing also you mentioned, Arash, which I fully agree with about the need for good science. But, as I always say, we should be also not allow the perfect to be the enemy of the good. In the middle of the pandemic, unfortunately, we had to do things at a pace probably that we never had to do before, because there was no time to waste. People were dying from the infections. Diagnostics had to be developed very quickly. Vaccine, for the first time in history, we have from the time of the discovery of the virus to almost within a year, we had a vaccine that was actually ready to be injected in people, so that never happened. And in a way, this rapidity, this fast pace also created problems for us in terms of acceptance from the community, because like one of the main comments we used to get, when we ask people about vaccine hesitancy is just like, this is so fast, like, we don't want to be the guinea pigs, how can we? So another, maybe I don't see it in the agenda, but I probably missed it. We need to start thinking about also systematizing research for some of the non-traditional research areas beyond just the clinical trials and the classic research, even research into, for example, better understanding how communities think, behavioral science research, because the main theme of the conference is more on evidence to impact. And if we really want to make sure that all this good scientific work is translated to impact, impact, we need to also focus on the receiving end, the communities that are at the end benefiting from all the good science that's happening. So would be good to get some in the discussion insight on how can we also as a scientific community and public health community have better data generation to help us understand what will make our scientific contributions more impactful on the ground as well. Anyway, with that, I will move. I think our next speaker, is it Mehrnaz or Ahmed? I don't see the full order. So should we move to Ahmed? It looks like he's unmuting. Yes. Okay, please go ahead, Dr. Mandil.
Thanks very much, Dr. Hajjeh. Can you see my slides, please?
Yes.
Thank you very much. Dr. Lubna Al-Ansari, the former Assistant Director General of WHO for Health Metrics and Measurement, the wonderful crew who put this conference together of Evidence to Impact, the International Society colleagues, ladies and gentlemen, it gives me great pleasure to talk to you about supporting research and ethics during the COVID-19 response. As you all know, in WHO, recently, just 2 years ago, a science division has been formulated, headed by the chief scientist, Dr. Sumayathan, including 3 departments: digital health and innovation, quality norms and standards, and research for health, putting for the first time all entities of research in WHO under one umbrella. As mentioned earlier by Dr. Hajjeh, we serve 22 members in the region. As far as health research is concerned, we actually follow the 4 pillars of the strategy on research for health, supporting it from the regional office in WHO, supporting meeting health needs through prioritization of research, strengthening health research systems through capacity building workshops, ensuring good research practice through standards and activities related to governance, making sure that evidence generated from research is actually translated into health policy making through our work in the region. Our unit of research promotion and development is the Secretariat of the Research Ethics Review Committee for the region, the Advisory Committee for Health Research, the Collaborating Centers Oversight Committee, and the Association of Medical Editors in our region. We support the broad agenda of ethics, bioethics, research ethics, ethics in medical practice, public health ethics, as well as publication ethics. We also are very proud that our region is the host of 3 of the 12 collaborating centers on bioethics globally, 1 in Beirut, 1 in Karachi, and 1 in Tehran. We also have very strict measures in our regional journal, which was referred to by Dr. Arash Rashidian, for the conduct, sharing, and publication of research on ethical basis. We also support all kinds of publication health ethics through ethics in emergencies, public health surveillance, vector-borne diseases, big data, and most recently, artificial intelligence, gene editing, and the response to the COVID-19 pandemic. Our ethics review committee has actually membership, half of which from outside WHO and the other half from within WHO. Any WHO-funded research has to be actually cleared by our committee. During the pandemic, we have expedited the ethical review, but making sure that standards are always kept and always observed. We have checklists which the PIs have to use whenever they're applying for ethical clearance, with a special section on emergencies, including the COVID-19 response. And in order to support decision-making and rational use of forces, there was constant need for research to generate evidence, as mentioned by Dr. Rashidian, and translating, disseminating to support health policy making. As a matter of fact, during the last biennium, the 2020-2021, and the current biennium, 22-23, we had identified priorities for research in our region. And these priorities included epidemiology and surveillance, community engagement, and IPC. And I give you some examples, like epidemiology of COVID-19 association with NCDs, mental health, and substance use, identification and handling of high-risk groups, the role of wildlife, domestic and companion animals, and so on. For the community engagement, a role of risk communication and community engagement in COVID response, and how efficient is disinfection of streets and open spaces. Many of these have already been discovered through research, which you are all aware of and being involved in. We also had priorities for health systems and services, such as comparing essential basic services during and before the pandemic, acceptability and effectiveness of remote delivery of medicines, as well as mental health services, transmission risks and patterns, effectiveness of contact tracing models, impact of the pandemic on countries with protracted emergencies, and most importantly, the implementation of the international health regulations during the pandemic. During the years 2020-2021, we received some 100 proposals, of which 17 were funded on COVID-19 research. But also, I want to say that we have other research grant schemes, like in tropical disease research, which is on TB, malaria, neglected tropical diseases, and HIV. We also had a special call for migration health research and a special call for international health regulations. So examples of funded research and where it has been done, as Dr. Hajjeh was asking a little while ago, we had 17 proposals funded in the United Arab Emirates, in Pakistan, in Palestine, in Egypt, in the Islamic Republic of Iran, as you can see on this slide, as far as the institution and the project which was funded. We also had research funded in Jordan, Qatar, as well as many in the Islamic Republic of Iran as well. We had research funded in Pakistan on exploring risk factors for severity, COVID-19 and slum communities, promoting maternal, mental health and children socioeconomic competence, as well as other research, as you can see on this slide. In addition to COVID-19 research, we actually covered a lot of research in other areas as well, as you can see on this slide, in Jordan, in the Syrian Arab Republic, Lebanon, Egypt, as well as Sudan and Tunisia. And you can see that this went beyond the COVID-19 to others. For this biennium, we had a new set of priorities because, as Dr. Rashidian was mentioning at the beginning of the pandemic, there were more questions than answers about the whole life cycle of COVID-19 as far as infectiousness, epidemiology, prevention, and control are concerned. So for this biennium, we thought that we would like to know more about the effective public health response at points of entry, the impact of the public health emergency operations centers across the region, the influence of the COVID-19 on transformation of health professional education, the role of primary care and how it could be strengthened by building resilient primary care systems, digital health interventions, including telemedicine, EMR responses on provision of NCD services, effective strategies to mitigate mental health impacts, health impacts of healthcare waste management practices, occupational health impacts, direct and indirect effects of the pandemic on newborn child and adolescent health in the region. As a matter of fact, we received another 100 proposals this biennium, of which 11 were funded. And also, we continued our small grant scheme for tropical disease research. So for this biennium, we covered research in the Islamic Republic of Iran, Pakistan, Oman, Qatar. And as I would like to say that these are all small grants between $10,000 and $15,000. And the titles of the funded proposal you can see on this slide. We also funded grants in Palestine, Sudan, and Pakistan on post-COVID-19 condition, characteristics of outcomes of opportunistic fungal infections, COVID-19 cases during the period of 20 until 22 in the Sudan, and so on and so forth. So, ladies and gentlemen, what we care about in WHO, and we support in member states, permeability of research outcomes within research and academic institutions, that we support knowledge sharing, especially evidence to policy, as this conference is about evidence to impact, and the outcomes of surveys to be shared with the people as well as the health policymakers in the region. As I mentioned also beforehand, we have our own regional journal, which has been quite effective in publishing the most recent outcomes of research in the region. But obviously, the research in the region is with challenges, some of which were referred to by Dr. Rashidian already, but would like to refer to another set of challenges with standardization of long-term, multi-center, multi-country studies, such as the Solidarity and Unity studies, access to certain study groups with necessary clearances, safety and security of collected data, accessibility to complete information and data, especially case report forms, many of which will include just the name and gender. And then when you go to comorbidity and you go to other reasons and other variables, they're not there. Observing ethical principles and considerations during research during the COVID-19 pandemic was quite difficult, especially conducting informed consent processes and maintaining confidentiality. The needs of intersectoral approach. We have seen the importance of health, social, economic, security, and grassroots organizations in conducting as well as sharing outcomes of research, funding opportunities, and obviously the culture of using evidence generated from research by health policy makers. Ladies and gentlemen, thank you very much for giving me this opportunity.
Thank you, Dr. Mandil, and thank you for also covering within the allotted time. I see that Dr. Hajjeh has already left. And I mean, for colleagues who may have joined a bit later, just she had another engagement that, as she announced at the start of the session within the World Health Summit, so she had to leave us a bit early. So I continue with the session, chairing the session. So following the two presentations that we have had so far, I have the pleasure to invite Dr. Mehrnaz Kheirandish, the Regional Advisor for Evidence and Data to Policy, to give her talk. Please go ahead.
Thank you, Dr. Rashidian. Good morning, good afternoon, good evening, everyone. Thank you for giving me this opportunity to present some of our experience, WHO-EMRO experience in enhancing the capacity of using evidence and data for policymaking during COVID-19 and, in response to emergency challenges. I am Mehrnaz Kheirandish, Regional Advisor for Evidence and Data to Policy at WHO Regional Office for Eastern Mediterranean. I will explain and present two main experiences that we had during the last few years during COVID-19 pandemic by development of some case studies that showcase how our countries in the region use evidence and data from different sources to respond and to address COVID-19 challenges. And also I will present the activities done in the region to enhance the capacity for conducting vaccine effectiveness studies by establishment of regional COVID-19 vaccine effectiveness study. So this is the concept, we called it integrated multi-concept approach for evidence-informed policymaking that presented by Dr. Arash today. This is a concept endorsed in 2019, which is promoted to enhance the capacity of using evidence for policymaking in the region at national level, which means different programs should talk together, should coordinate with each other to enhance the efficient policymaking, informing by evidence. So in that case, we tried to develop some case studies that show how countries in our region use evidence for policymaking during COVID-19 pandemic. We wanted to document and to publish these case studies, these lessons learned, these experiences, to share our experience with each other together, to enhance our capacity for evidence-informed policymaking, not just for now, of course, for future emergency situations. I would like to mention that we did these case studies and we developed these case studies mostly with our members for our regional network of institutions for evidence and data to policy, which includes 33 member institutions from 21 countries in the region. This is a summary table of the case studies. As you can see, there are 15 case studies from 13 countries in the region. Yemen and Afghanistan have 2 case studies. And you can see in the middle column here that there are different sources: surveys, health information system, tacit knowledge, routine data, published studies, WHO guidelines that used by different countries in the region to make policies on vaccination and other types of policies at national and subnational local levels. That I will just present some of the examples in the interest of the time. So we had case studies from Afghanistan, Jordan, Oman, and Somalia that they show that how national surveys, how the evidence from national surveys used for policymaking. For example, there was a household national survey conducted in Afghanistan to determine the extent of COVID-19 infection and mortality to address infodemic and misinformation through social media. In that case, through that, that's the results of that survey, they increase the use of evidence, and also they decide for social health and public health measures. There was another study from Jordan that showed that how Jordan used the results of survey to develop a prediction model to support policymakers for deciding on social measures and public health measures. So also these are different other types of cases done in our region by Oman, Somalia, and other countries that through the surveys, they develop or they own or update their own national strategy, their vaccination and deployment policies. And through those interventions, they resulted in increasing vaccination, in increased uptake of vaccines, as well as to managing the infodemic and misinformation among public, as well as to decide for public health and social measures. Also, there are case studies from, for example, Afghanistan, Palestine, and Yemen that showed how health information system and how routine data and surveillance system used for informing policymakers during COVID-19. For example, in Afghanistan, they used the bed occupancy rate as well as positivity rate to develop a national algorithm which used by policymakers, by senior policymakers to decide on public health and social measures. There were a study from Palestine and Yemen that showed, for example, in Palestine, different data from different sectors in health system, public, private sector, as well as different levels of health system. They use all this data to establish and to update some vaccination strategy and social interventions that through them they decide for public health and social measures, and also they increase the vaccination among people and they increase the population coverage. There was a study from Iran that showed that how the country used the rapid response program to better synthesize and package evidence to address policymakers' questions in the timely manner. In Iran, they use this system to address at least 30 high important questions raised by policymakers during COVID-19, and the policymakers use those evidence synthesis to make some policies at national level in the Ministry of Health. There was another case study from Yemen that showed how WHO guidelines used by Yemen to develop some vaccines delivery strategy, and as well as some other national strategies in response to COVID-19, which through them they establish a store of oxygen supply, and also they increase vaccine uptake in the country. So as you can see, there are different case studies from different countries that show that how different sources of evidence and data can be used to make policies, efficient policies at both national and subnational and local levels. This work showed, again, just showed us that how evidence and data is important for making efficient policies. And also they showed that how the high demand from our policymakers to access evidence, mostly evidence comes from local data in a timely manner. Also, we understood that these different sources can be used for different purposes to implement several policies at national and subnational level. But one of the other and main key findings from this study was that we saw most countries in our region, they use routine data, health information system, and surveys, the results from surveys to inform policy making, which show that we need to build capacities, to enhance capacities in conducting and use of other sources, also including knowledge translation processes to inform policy making. This not just mean that we should enhance this capacity for generation of these knowledge products, for generation of this evidence. Also, we need to build capacities among policymakers and policy developers in appraising and in use of these products and evidence for policymaking. Of course, there were challenges that countries face during use of evidence for policy making, stakeholder engagement, community engagement, several other challenges. But the main of them, I can just say that the limitation that our countries face in sources, human and financial sources for using evidence for establishment new structures, as well as limitation and the limited capacity in health information system, having integrated comprehensive health information system at national level was among the most challenges that our countries had in the region. Also, as I mentioned, there was limited capacity in technical expertise in other sources and areas of that multi-concept approach that I showed earlier. For example, knowledge translation processes, modeling, HTA, policy briefs, which are the key sources of evidence that can be used to for policy making. We have limited capacity in conducting such studies, and also there was challenge in aligning and I can say adapting the national policies to subnational and local policies. This was also the same that we just saw from some of the countries that they had challenge to adapt the global, the WHO guidelines tools to their national context. That it means that WHO should work more to enhance its adaptation tool to support countries for adapting and transferring global data to national context. And I just want to inform you that we will have one hybrid seminar in October, this month, 26th and 27th of October, to present all these case studies. Countries will join us and they present the case studies with the lessons learned, challenges, and experiences to share this experience. This seminar will be an opportunity for us to share our experience together and to enhance our knowledge and to raise our knowledge to see how we can enhance the capacity for evidence-informed policy making in our region. That I want to invite you to join this seminar virtually. Also, another initiative done in the region was building capacity for implementation of vaccine effectiveness study, which the main purpose of having this was, we know that there are many factors that could affect the effectiveness of vaccines in the field. And so it shows that we all know that the real world studies is very important to make decisions for the countries on vaccines and immunization programs. But at the same time, there was limited studies conducted on some types of COVID-19 vaccines, including inactivated and protein products, which these vaccines were among the most vaccines and common vaccines used in our region. So we understood that we need to just implement some studies to produce some data on effectiveness of these types of vaccines in our region for better decision making. Also, we do need to have a capacity in the region and also at national level for conducting such studies in the similar situations. And also we know that these kind of studies can enhance efficient decision-making informed by evidence, for example, in immunization programs. So these were the main aims and purposes of establishment of regional COVID-19 vaccine effectiveness in ISEHC. And in that case, we had two main, I can say two main area of works that we did. One of them was enhancing the processes and the structures, and another one enhancing the technical capacity of conducting such studies. To enhance the process and the structures, we established the regional network and team, which includes different disciplines from pharmacies, economists, epidemiologists, public health, and also epidemiology consulting firm to support regional office and countries in the region for conducting these studies. And this network and team was, we developed this network at the beginning of establishment of this regional study to support us and support countries from the beginning stage, from the starting point of conducting these studies to the end, from designing the method, setting everything to the end, which is data management, analysis, and reporting. We created the dashboard, the COVID-19 vaccine dashboard, which I just show you later, a kind of a snapshot of this dashboard, which is the regularly update weekly. In that dashboard, all studies in the region on COVID-19 vaccine effectiveness studies are included, just to, because we want, and we track the studies on COVID-19 vaccine effectiveness in the region and include this dashboard updated regularly to help us to share experiences among countries. And that's the lessons learned from different studies conducted by different countries among each other. The regional ethical clearance also issued for the purpose of having this regional ethical COVID-19 vaccine effectiveness. And also we established the central data entry platform, which is in REDCap, that helps countries to collect and manage the data management and collection in a standard way, and also help us to pool this data, to develop some regional data for having also to be able to support countries and to advocate better for policy making using regional data. Also, there were several different programs that help for capacity building. For example, we had different workshops in 2021, also early in 2022, on the methodology for implementation of this kind of studies, as well as how countries can use REDCap data entry platform to collect and to manage data information. Also, we did several types of technical support for the countries in the region, as well as from the beginning setting the designs, the structures, the methods, as well as data management. As I said before, this is the snapshot of the dashboard of this COVID-19 vaccine effectiveness studies in the region, that all main subjects and details for these studies are included in this dashboard and updated regularly, weekly, that and through tracking these studies, we share our experience and lessons learned and challenges with each other. Okay, if I want to say to categorize the way that we did, there are two main categories of countries in our region. There are some, as you can see on the right side or right hand side here, there are countries that they are they develop and they are conducting and implementing COVID-19 vaccine effectiveness studies independent of WHO support, which also are included in our dashboard. There are so many studies, mainly from Emirates, Qatar, and Saudi Arabia. And also in left side, as you can see, there are countries that they ask us support to technically support them and also financially support them in conducting such a study. That whenever that we receive any interest from countries, we start supporting them, even in providing the proposals, the methods, everything. And then and finally, now we have 4 countries in the region, which are Iran, Jordan, Egypt, and Pakistan, that participated in regional COVID-19 vaccine effectiveness. And this is still open to countries in our region. If any country want to participate in this regional vaccine effectiveness study, they can contact us, and we will start a meeting and discussion on how they can join this regional study. As you can see in this table, as I mentioned, there are 4 countries, Egypt, Iran, Jordan, Pakistan, and 2 of them are using the cohort study in healthcare worker methods, and 2 of them are using the test negative case control design in severe acute respiratory infection study. So we have, there are different institutions that each of them includes different hospitals and provinces participated in the national study. And what we are doing now, the implementation of this has started, and the enrollment of the cases has finalized. And now we are collecting the data. These all are 1-year study, which after this 1 year, we will have the regional pool data from the countries, including the other countries which will also join in this study. There were several challenges and lessons learned, of course, during this work, as well as to standardize the study designs, the methods for conducting this study within different countries, to reach the adequate sample size, as we know that because of the high coverage of vaccination nowadays, because of the vaccines, third doses to the boosters of the vaccine. So we have the high coverage of vaccination, and because of that also we are in challenges to have this. We had challenges in terms of having the enough sample size for the studies. Emerging of new variants, as well as doing genomic sequencing, which is not possible in all countries and settings that we include in the study, as well as having the different vaccination protocol and combination of vaccination within the countries, among the countries in the region. They were among the most challenges that we had. That to address them, we developed a code book, a standard book, guidelines, guidance. We updated the WHO guideline to be able to address these challenges. And we will have 2 region-wide workshops on 15 and 17 November coming months. That in that workshop also we will discuss in details all these challenges and how countries can face them and can respond all these challenges. That again, I would like to invite who is interested in vaccine effectiveness studies to join this workshop as well. At the end, I would like to thank my colleagues who help us for conducting this regional vaccine effectiveness study, as well as my colleagues, Dr. Rashidian, the Director of Science Information Dissemination, and my colleagues, as well as the countries NET2P members who participated in development of the case studies on evidence-informed policymaking. Thank you. This is just, I provided you with a link here, which through this link you can access all workshops training materials, whatever that I mentioned, the results of our reports, you can access through this link. Thank you so much. Thank you. Over to you, Dr. Arash.
Many thanks, Dr. Kheirandish, for the very informative presentation. So I'm just briefly reminding everyone. So we had three presentations, an overview of different programs that have been conducted in support of research in response to the pandemic. Then a focused one on the call for proposals for priority areas of research in terms of the small grants in countries of the region related to COVID, as well as the regional support for ethics under emergency situations. And then another talk that was again focused on two areas of work, the case studies of use of evidence, data and research for policies in response to the COVID pandemic in countries of the region, 13 countries, and WHO programs for enhancing capacity for conduct of vaccine effectiveness studies, as well as supporting for large-scale studies in 4 countries of the region for vaccine effectiveness. So I haven't seen, I've been actually observing chat and Q&A sections of it. I haven't seen any question. I've received comments from colleagues thanking the presenters. So we are also grateful to you to be in the session, listening to us. I saw a couple of comments from Professor Randa and also other colleagues. And colleagues are also suggesting that we do further work to enhance communication. I think that's from Lubna. So, I mean, if anyone wants to raise question, I assume it's possible. We have few minutes to the end of the session. So if any question, any feedback, any comment, any advice, please take the floor and raise that to the session. I see one hand up. If I can just give me a second to learn how to. Oh, that's from Loka. Professor Aaron, sorry, the floor is yours. Do I need to do anything to give you the floor, or it happens? Whoever who is the host, please can you make it possible for Lubna to talk? Oh yes, she's with us. But please go ahead, Lubna.
Okay, I must say I've really enjoyed this all the presentations. I've enjoyed this session very much. There is a lot that is being conducted by your department for the region. Our region is not the easiest to conduct research and make use of evidence in making policies, but you have achieved a lot. And I'm really proud of what I've listened to. Of course, challenges will remain, but my question now is not someone who knew something about it from the inside, how the WHO operates, but for the general audience, people who don't know exactly how the WHO, how to communicate with and how to talk to them, how to work with them. What advice would you give so that you can establish a better or a more effective dialogue with the medical community and hopefully leading to an impact? Thank you very much.
I mean, many thanks. A good question. I would say for the professional teams, etc. Sometimes being in direct contact with WHO is not easy. So I mean, that's understandable. I mean, formally speaking, so WHO works through the country offices. So any teams inside the countries, I mean, they can approach the country office for areas and then reaching us. But when it comes to science, data, and research, obviously, it's a more wider relationship that exists. One role is our role to make sure we communicate better the work of the WHO, to also inform about opportunities. So we heard, for example, from Ahmed about the call for proposals and the linkages. So those are open to any institution within countries of this region, within the 22 countries. or Mehrnaz, in one of her slides, she had a link to a web page, and so the website of WHO is also a very good resource to get to know. We also get publish certain reports, publication. I had a link to one, for example, presentation. Beyond that is sort of, I mean, when people know each other in terms of communication. So in these areas of work, I mean, obviously through the website of the conference, colleagues have access to our emails, and you are more than welcome to approach us. I mean, anyone who has questions, queries, but I mean, we do our best to answer and also to link you to the teams that are relevant to the topic where possible. So the main thing becomes, I mean, the other thing is structurally through collaborating centers. So when there's important academic teams with capacity, they can establish to be a collaborative center of the WHO. So in your country, Lubna, I think Ahmed, correct me if I'm wrong, I think there are 5 right now, 5 collaborative centers in Saudi Arabia.
There are more than 8 now.
Oh, mashallah. Okay.
Our WR, Dr. Ibrahim Zik, has been so active, so they have doubled. I'm happy to say that.
Okay, excellent. So 8 collaborating centers. So that means those collaborating centers and institutions where the informal agreement and informal collaboration with WHO. That means their team also with the relevant teams in WHO. The other area is the network that Mehrnaz was referring to, network of regional network of institutions for evidence and data to policy, Net2P. And right now, Mehrnaz, I think 33 institutions in the region as a whole are members of the network, I mean, from 21 out of 22 countries of the region. So again, that network is open. Obviously, I only talk about the number of collaborative centers in Saudi Arabia. There are many more in the region. Overall, I think it's, I mean, Ahmed, you can give the final figure, but it is about
55 now.
55, okay, excellent. So those are structured relationships, but I guess, so the main thing becomes, I mean, the other area is that to enhance capacity for further work, especially multi-country, high priority, high impact research. That's an area that we would like to do more work in these areas. And also there is a consultation right now happening in the WHO on enhancing capacity in the conduct of randomized controlled trials, especially large scale randomized controlled trials. If you noted my presentation, I mentioned, I mean, many randomized controlled trials in response to COVID conducted in the region didn't have a good design, didn't have a good sample size. I mean, not appropriate at all. And that's an observation that has been seen elsewhere as well. Basically, I mean, the general, whatever added to the knowledge in terms of management of COVID, what came from very large scale randomized controlled trials happening in more than one country, or if in one country with many institutions involved. So single institution or cities are rarely an answer to real public health questions. So that's the issue of importance to enhance. So if teams have the capacity to lead such agenda and also have the ideas how to enhance such multi-country works, I think that's the other area that we can do further. On evidence to policy as well, I mean, so we are trying to bring different experience of countries from one setting to the other. So I guess these are some ideas, so maybe Mehrnaz or Ahmed, if you want to add a couple of words.
Thank you very much, Dr. Rashidian. I would like to thank Dr. Lubna for her question. And obviously, I just want to say that there is nothing better than our web pages. And these web pages are available on HQ level, regional level, and country-specific level. So more than 200 people are participating in the conference today. And you are more than welcome to actually visit our web pages for research, for evidence to policy, for information systems, for health observatories. They're all available around the clock, public access all the time for all of you. And I also want to mention that the country offices in your countries are good resources for information. And this is across the 21 of the 22 member states. The only country which doesn't have a country office is the Emirates, but other than that, all countries have country offices, usually based in the capital of your country. Thank you.
Many thanks, Ahmed. Mehrnaz, maybe 1 minute comment if you have.
Thank you.
Okay. Many thanks. We are exactly on time, so I have to close the session to give you 5 minutes for a break. I see that moderators of the next session are joining, so welcome to the new moderators as well. But my understanding is that the next session is going to start in 5 minutes, so the audience would have 5 minutes to rest, to relax. And again, many thanks on my behalf and also on behalf of my co-panelists, Ahmed, Mehrnaz, and Rana, who was with us and left earlier. So thanking the conference organizer, especially Lubna and her team, but also the international panel of the conference and the great audience that we had today. So we have a workshop later today on policy brief development. So that's on the agenda. So within that workshop, the three of us that are in the session will be with you. So